Good morning, all, and welcome to your October 2024 Public Employees Benefits Board meeting. I'm ready to call this meeting to order. Good morning. Let's go ahead and begin with roll call. Devon Martin, I see you. Good morning.
Good morning.
Greg Clauser, are you with us today?
Good morning.
Greg, Cheeky Flowers is excused today. Andrea Fultz, are you here with us?
I am here.
Good morning, Andrea.
Good morning.
Kimberly Hendricks, are you with us?
Good morning.
Did I hear Kimberly?
For me?
I'm working with only one screen this morning, so I can't see everybody at the same time. Is Kimberly with us this morning?
She is. Her volume is extremely low, so I could barely hear you at the beginning, Kimberly, and then couldn't hear you at all. But I see you're off mute, so I don't know.
Very quiet. Very quiet.
All right, that person was also very quiet, but Kimberly is here. Good morning. Sean Parkman, are you with us this morning?
I'm here. Good morning.
Good morning, Sean. Emily Wong, are you with us this morning?
Yes, good morning. I'm here.
Good morning, Emily. And Rep Rob Nose, are you with us this morning?
Yep.
Good morning, Rep. All right. That brings us to quorum, no problem. Board members, did you have a chance to review the minutes from the September 17th PEB meeting?
I've reviewed the minutes and I would like to make a motion to approve them.
Thank you, Siobhan.
I can second that.
Thank you. Sorry, who was that?
Greg?
Thanks, Greg. All right. Thank you for that second. Let's go ahead and vote. Andrea Fultz.
Approve.
Thank you. Kimberly Hendricks.
I vote to approve. Can you hear me?
Yes, barely. Sean Parkman, how do you vote, please?
Approve.
Thank you. And Emily Wong, how do you vote, please?
I approve.
Thank you. And that brings us to our first item on our agenda. Andrew and Emery, I'll hand it over to you to talk with us about working toward equitable access. Good morning.
Good morning. Thank you so much. Hopefully everybody can hear me. Okay, I'm getting some nods. Okay, great. All right, good morning, everyone. I'm glad to be with you today. We're excited to talk about this topic, which we have titled Working Towards Equitable Access, and hear from you all on the board on your priorities as it relates to advancing your goals around equitable access for urban and rural members through the upcoming RFP. Before we launch into that topic, though, let's take a moment and do a quick reminder, similar to previous presentations. Excuse me. And so, as I noted, the focus of this presentation is a topic related to the upcoming RFP. And so for these portions of the board meetings where we're discussing the RFP, we are requiring that potential bidders refrain from actively participating in this discussion, either through live comments, through the chat function, and the purpose of this requirement is really to sort of safeguard the bid process in terms of its integrity, make sure we have a level playing field for all bidders. And so we do thank you all listeners for your cooperation with this requirement. There will be opportunities to pose questions and have those questions answered once the RFP is released. And so know that you will have that opportunity at a later date.
Thank you, Andrew. Thanks for the reminder. I forgot to share it and I support it. It's super important for us to protect the space and the bid process, the RFP process. So thank you for your participation.
Well said. Thank you, Don. So I think we can jump to the next slide. So we've got 90 minutes today for this topic. We'll start with an overview of PEB's history of prioritizing this topic. We'll review some data analysis that we've completed that's going to help shine a light on some of the issues that we're seeing within the PEB population around disparate outcomes and other inequities based on where folks live. We've also included some lived experience data points that we'll talk through that we pulled from PEB member surveys, just to make sure that we're including the member voice in this discussion and keeping member experience front and center. We'll go through some issues that have been raised over the years by the board, by OHA staff, as well as some that Mercer has brought forward to really set the stage for what it is that collectively we're trying to solve for when it comes to crafting the RFP in such a way to address some of the inequities that we know exist based on where members live. And so, as always, just stop me or other presenters with any questions, comments, or perspectives. I'll try to keep an eye on raised hands, but team, just keep me honest if I don't see it immediately. Please just stop me. And so PEB has a long history of talking about and working on this topic. And recognizing that healthcare needs do vary based on different geographies, and a long history of striving to address that and address the inequities that like I stated, we know exist based on where you live. And so this is not a new topic for the board, although with the upcoming RFP, it affords us an opportunity to delve deeper than we have in the past. And so it should make for a really good discussion. As you all know, Oregon is a largely rural state. The urban centers are along the I-5 corridor in Bend, and the remainder of the state is largely rural. When we say rural in this presentation, we are aligning to the definition set forth by the Oregon Office of Rural Health, which defines rural as any geography that is 10 or more miles from a city center that has at least 40,000 residents. And so we will look at a heat map here in a few slides, which will show the distribution of PEB membership and just provide a nice visual for how many folks are urban versus rural. So we know, like I said, we know that there are inequities that exist between urban and rural settings. PEB has identified rural and frontier communities as a priority population in recognition of that fact, recognizing that rural communities have been disproportionately impacted by health inequities. And furthermore, during the retreat that occurred 2 years ago with the board, PEB did reaffirm its goal to have plan equity across the state. And so that's a little bit of the history. We have included a condensed version of PEB's values in these blue boxes here. Improved health, improved quality, affordability, and equity. We just wanted to bring these forward so that folks could keep them in mind once we start talking about the opportunities and think through how each opportunity moves the needle based on one of these 4 values. And so that'll come a little bit later on in the presentation, but we did just want to give these a moment so that folks can keep in mind once we get to that section. So let's jump to the next slide, please. So when we talk about defining today's topic, I think it comes down to the fact that healthcare is provided differently and based on where you live, and there are unique challenges based on where you live. And so we're going to go through some of those challenges and factors in a lot of detail in this presentation today. Some of those factors include availability of providers. That could be primary care, behavioral health care, specialists, hospitals, and related to availability, the distance of those providers. We know that in rural parts of Oregon, travel time to a patient-centered medical home is going to be a lot longer for those rural members than it is in urban areas. Another factor that is more applicable for the rural areas is broadband access, and the fact that there are parts of the states where that does not currently exist, which presents challenges for virtual care. We also know that cost of services varies based on geography. And so when we think about affordability for members, we've got this factor around cost variability that is having a real impact on affordability for folks based on where they live. And so the challenge that the board faces is how to structure a program that meets the needs of a very diverse population, including geographic diversity. And so I think that'll really come to light when we look at this visual here. You've got a lot of urban members, a lot of suburban, a lot of rural, a lot of frontier, and that does present some challenges. And so with all of that said, these slides were really intended to set the stage and define the scope of the conversation today. And so we're going to shift gears now, and we are going to talk about PEBB's current state and get into some data analysis to look at what issues we're seeing when we look at the at PEBB's data. So with that said, Emery, if you want to take it from here.
Sure. Thank you, Andrew. Thanks for that overview. So current state, and I think this is, everybody knows this, but we just go on and lay it out again. It is different based on where you are located. So urban Oregon, so we are, as Andrew mentioned, down the metro area or I-5 corridor. There are more options. Kaiser HMOs located there. Kaiser's networks generally is just basically the Kaiser Permanente providers and facilities, although they do have some other facilities and providers that are contracted and part of the network. Moda and Choice, basically the same plan design, but they do have different networks. The OHSU is one of the bigger ones, Providence Networks, depending on, in the urban county. So you do have a little bit of a choice between Moda and Providence Choice in this case. So that's for urban, but that does not include Bend, Central Oregon. Central Oregon does have Moda and Choice, but it does not have Kaiser. So, but for rural Oregon, generally there are 3 plan options. So you do have Moda and Choice as well as the statewide PPO. However, there are a couple counties, I think maybe 3, where Choice is not available. And Moda is available in some Washington and Idaho counties that are along the border. The networks don't have as much differentiation like it does for Moda and Choice in the metro and urban areas. So there is considerable overlap in those rural areas. And then outside of Oregon, not including the places where we're considering that Moda is located, or where potentially members live but work in Oregon, the option for them statewide. So you do only essentially have one option if you are not in a county where coordinated care plan is located. You do have higher cost sharing and higher contributions as a result. Kaiser does have the lowest cost sharing. Essentially, the copays are pretty low and no deductible if you're in an HMO plan, but the other plans outside of the urban areas that has more cost sharing, as one of the future slides, next slides will show.
So Emery,
yes, go ahead.
When you say it had in the rural areas, there's less differentiation, you mean among the provider network?
Yes.
Is that what you mean? That in other words, Providence and Moda would be contracting with the same people?
Yes. Yeah, there's in a lot of these locations, and when actually, let's go to the next slide. So geographically, this is the heat map that Andrew was talking about. So when we are talking about places like, not necessarily down, in Klamath Falls, I think there might be a couple facilities that are different. But if you talk about the Northeast here, there is definitely a big concentration of blue of members. The darker it is, the more members, PEB members there are. So when we're talking about Pendleton, LaGrange, Umatilla, there's big. I mean, in Washington, there's additional, but there's one facility in LaGrange, so Pendleton, in those areas. So it's like the differentiation isn't there because you only have one facility that can essentially members can go to, and then would be contracted to fulfill that. So there's more options outside, and the provider systems. There isn't necessarily a OHSU legacy, Providence, the Kaiser, differentiation where these facilities, provider groups are essentially, have their own inter-financial connections. And, you don't get some in others, and some are in Moda, some of them are Choice, some of them are Kaiser. You don't quite have that possibility because you don't have the provider number of provider options in some of these locations. So that's what I'm referring to. There is some differentiation here and there, but generally it's there's definitely less, and so that does have an impact on prices and access and things like that. Does that help answer your question, Sean?
Yep, just double checking. I was understanding what you mean.
Yeah.
It would be interesting if we understood like how much, like we're talking 90% overlap, 95, 98%, you know what I mean? It would be interesting if we had like a little gut check of like how much overlap. Yeah. At some point.
And that is something I think just time didn't quite permit. We were trying to look at some of the provider stuff, but yeah, it is definitely one of those questions. It's like how many providers are currently being used by different members? How many? What's the number of providers that are currently being utilized, as well as how far the members have to go to use those providers. There was a question about pharmacies. We are working on that for the retreat, but we can try to take some of these and see what we can do in the next month or so. But that is definitely a question. It's like, can you actually get like a choice of providers, or are you basically limited to certain providers in these areas? And if that's the case, it doesn't make sense to have multiple options, because if you're potentially diluting your purchasing power and diluting the ability to have value-based payments if you have multiple healthcare, multiple providers in these systems. So that's some of the questions that we might be exploring.
Yep. I feel like this is the sort of key discussion for us in the new RFP, because I think many people over time have been confused by this point, policymakers and various others, that the idea is if you add more plans, you're going to somehow solve the lack of provider access. And I think our members have that in their mind as well. If we have more plans, there will be more doctors. And that is not the score in rural Oregon. The number of doctors are the number of doctors. It's just when you have more plans, there's more plans trying to contract with the same doctors, which means it's a monopoly. They get, there's more same resource, bunch more demand. Essentially, the plans are trying to purchase the doctor's time, and there's more of them. So they, in order to get them into their plan, they throw more money on it. So it just kind of makes matters worse, or it could. I'm just saying it could. It doesn't solve the problem by having more plans. That was my point, per se, unless the plan brings more providers with them somehow, which would be interesting. But that's a really tricky discussion with a lot of Oregonians, because I don't think that's well understood. Generally speaking, we're talking about the same people. It's just that they have different contracts with different organizations. But you can't multiply the people just because there's more contracts.
And this presentation, as we get ahead, we do talk about maybe ways that PEBB could help with other initiatives or funding to try to get more providers. Create the provider base, really getting working with institutions, hospitals, and other universities to essentially get these members, or potentially help fund people moving to rural and urban areas and frontier areas to get to get more behavioral health, get more primary care providers, and other things like that. And so some of those things are much longer term. It's not something that's going to be solved instantaneously, but things that could be priorities that PEBB has in terms of who you're going to contract with, if the plan's going to do things to increase number of providers in some of these areas. Because you end up with situations like, with I think with PEB, VSP, or like the vision plan, where you end up having like some providers who just, I don't want to be part of this network because I can get more money outside. It's like, well, it's like what can we do to increase the number of providers and to increase the access for members? And so some of those things, we'll explore that a little bit further in this presentation. But not to get too far ahead of ourselves, but just kind of going back to this map, I don't know, we talk about where the members are, and this kind of this is by zip code, so it gives you a little bit more of a breakout, but there are definitely some darker zip codes where you might not think. I think the Northeast was, for me, the biggest one, where there's so many more members than I was anticipating. And then you do have the pockets of population down south in that Klamath Falls, Grant Pass, Medford area as well. Emily, your hand, you had a question?
Yeah, and I don't want to disrupt your presentation too much, but I do have a burning question.
Yep.
I was part of a group that helped stand up the CCOs at OHA, and I was part of a provider access work group. So this is years ago, maybe 2012, something like that. And I just remember, and I see the note that on the current state that Washington and Idaho clinics are also part of who Oregon goes to see for healthcare. And I remember us talking about Eastern Oregon at the time and how a lot of Latino members were facing discrimination at the clinics in Oregon in that area. So they were actually opting to go to the Idaho clinic or Idaho health system in order to, avoid the discrimination. So I'm just wondering, like, for this, I love this map, this heat map. Is it possible to show like the Washington state parts and the Idaho parts, like, for future, or just to get a better handle on the current state visually?
Yeah, we can definitely do that in terms of the members. The zip codes, it's the information that comes through. We can definitely add those. I wanted to, focused on Oregon, I guess in this case.
Yeah.
But we can definitely include that.
Okay.
I know I was having issues playing with the map in terms of trying to get population sizes and everything working out properly. But this worked out pretty well for now. We can definitely provide an updated map for the retreat.
Okay, it's a great map. Thank you for your efforts.
Yeah. Okay. All right. So actually, moving on to the next slide. So taking a look at some of the cost and demographics by region. So this is, we break out these regions, urban, rural, and then kind of those are a combination of some of these other sub-locations there to the right. So we do have essentially alphabetically Central Oregon, which is what we label as Bend, just nodding to my own location. So we also have the coast metro area, which is essentially Portland, the Portland metro area. We have the northeast section, southeast, southern I-5, that's down where towards Klamath and Medford and those Roseburg, those types of locations. Willamette Valley, so that would essentially include Salem as well as Eugene and Corvallis, and then outside of Oregon. So we have some of the demographics here. The ones I kind of wanted to focus on, because there are a lot of numbers, they're ones that are colored. So green essentially would be lower, the red's higher, and then PEBB on average. So the member age, there is a bit of a difference. The average age is probably around 34-ish for the members. So that does include employees, spouses, domestic partners, as well as kids or dependents. So the more dependents you have, the lower number you have. So the Northeast and Southeast, they're pretty young, 32 compared to 34 on average. They do have more dependents if you take a look at the average contract size, but even with that, they are still younger than PEB on average. So those locations have younger, more families in this case. The coast, uh, 36, so they are a bit older. They do have more retirees, so that is building up the age difference there, and they have fewer dependents. Not significantly fewer, but they do have fewer. But there are more retirees on the coast, which is not surprising considering some of those locations and where people like to retire to. The risk score relativity. So this is basically what the risk score is, and again, that's like a measure of essentially how much acuity or how much they should cost relative to the PEB average. The big one is the Northeast. The cost difference there. Southeast is also lower cost, but the Northeast is definitely a lot lower cost here in terms of risk. So the risk is about 12% better than PEB on average. But despite that lower risk, their cost, if you go down to the very bottom, the regional cost, the cost of services for them is much higher. Their cost, the cost of the providers is about 17%. And that's not just unit cost, it's also potentially the usage of services as well. So we didn't parse out, or we're not able to parse out the difference between, whether something's overuse or like the quality of usage, the efficiency of usage versus the actual cost. But this is really, if you're saying average PEB member was in, overall, how much would they cost if they were living in the Northeast? On average, they'd be about 17% higher. So that's part of the issue with provider access and maybe the leverage that PEB has or the plans have to contract with providers in the Northeast. The cost is definitely quite a bit higher. If you talk about urban Oregon, the cost is lower on average. You have a little bit more competition. You may, the way the providers provide services maybe a little bit different, but those living in the urban areas are going to be about 2% lower cost than PEB on average. The coast is also pretty high cost, 12%, almost 13% higher, and the Southeast is 10% higher. So there's definitely some differences in the cost of services. But the line above that with the member out of pocket as well, there are two locations, especially basically the urban areas where Kaiser is. You have the lower cost sharing. So we're talking about like $150 or so per year per member, but there is definitely a difference in the member average out of pocket amounts, depending on whether you live in a rural area or if you live in an urban area. So the plan design options do make a difference. Go ahead.
Yeah, and Emery, when you're talking about costs that people pay, you're not talking about the premium share. You're just talking about deductibles and
yes,
copays.
I'm just talking about deductibles. Yes. So for outside Oregon, the member out-of-pocket cost is pretty similar, but a lot of those members only have access to statewide, which is 5% contributions. So their actual cost, if you add in contributions, would be higher than those who have access to choice or motor.
Emery, I don't know how you would know, but I'll ask anyway. Is it possible to know these regional differences for other plans other than PEB? Like, is this just a PEB contracting problem, or is this like pretty much everyone who buys insurance, buys services in Southeast pays through the nose? Like, is there any sense of that, or is there any way to prove that, or just checking it?
Yeah, we do have some information on that. I don't think we, I'll have to double check to see if we split it out by the specific locations. But we do, Mercer does have data that we've kind of parsed out this information across the country. And so the cost of healthcare in the various locations does differ. And we can get some of that information on. I'll have to double check to see how much Oregon's split into in terms of the information we have. But this cost difference, it is something that happens for other plants as well.
It would also be that good to know. If you can't get inside of Oregon, what other plans are paying, and I understand we probably can't get to the contract level although that would be cool, price transparency. But at least having like compared to some kind of national average cost, I'm talking unit cost, um, cost of services. It would be at least interesting to be like, wow, your Northeast quadrant region is higher than like, 80% of the rest of the nation. Like, that sort of thing. I mean, it would at least be interesting as a gut check of like, what are we doing here?
Yeah. Well,
I know.
you're going to be in. Yeah, go ahead.
Yeah, sorry. I was having sat inside the health plan world for a number of years. Usually like when a carrier contracts with a provider or healthcare system or facility or whatever, they don't have client specific rates, right? So MODA contracts with Dr. A or facility B, and that's their contract between those two entities. So the other piece of it is benefit design, how our co-pays or co-insurance, set up. And that's more in the control of PEB, right? Are you paying percent of charges? Are you paying a flat rate co-pay? That would make difference in terms of what individual member would experience. The contracted rates, of course, fall to you at the end of the day. So there are those two things. And then there's, of course, clinical efficiency and utilization patterns, which is kind of another number, right? Like how well people are performing.
So, Sean, in terms of your cost of the providers and the contracting, we've been looking at percent of Medicare, and with the IWG, and James is going to be chomping at the bit. We're going to be doing more on that. We're going to get some information that's probably going to help, illustrate that issue by the plans and the locations, and we'll work on that in IWG, and as well as maybe bring some stuff to the PEB board as well. But more to come on that sort of front.
Thank you.
But that is going to be a key part of the RP. I mean, the pricing and the networks. I mean, that is, it's not just the cost, but it's also, with Mary Kay, it's like how the care is delivered, and so it's all part of one big, it's not a puzzle, but it's all entire package in this case. Okay, moving on, and thank you for the questions. The more questions you have, that's great. We can definitely bring some back for the retreat if we don't have time, but please ask those questions unless you're a potential bidder, and then please don't ask those questions. Okay, so next slide. Okay, so some of the utilization differences by the region. So we're taking a look at standard utilization numbers there at the top, and then we are taking a look at some of the costs, which, I guess it's a little bit just a preview of your point, Sean, with the cost per service by different locations, as well as some of the screening rates. And so once again, green is below or better for PEB, and then red is essentially worse. So at the top, I think some of the big ones, I mean, there's a lot of numbers here, but the biggest ones that kind of stand out. The inpatient days for the Southeast, they're quite a bit higher, about 250 days per thousand. So average member is in the hospital for 0.25 days compared to about 0.2 on average, or actually a little bit lower than 0.2 on average for PEB. So we haven't really looked at why the Southeast is so much higher, but they are definitely higher in this case. And the acuity of those admits seems to be potentially higher, with the days per admit at 5.6, which is quite a bit higher than PEB on average. The lines below that, kind of like the ER visits, that one I think is, I don't know, this is like indicative of the access issue, I think, to me, or the way services are being rendered or used. Basically, the coast and the Northeast and Southeast, so especially Northeast, Southeast, the usage of emergency rooms is much, much higher. Than, we're talking 20 to about 40% higher, or I guess more like 20 to 30% higher than PEB on average. And the number of users that have 3 or more ER visits is 15% in the Southeast. So people are using the emergency room quite a bit. They are using it quite frequently, and that's definitely not the cheapest way of getting services, as shown in that cost section. But that is a big access issue. So what can be done about that? Um, the office visits, number of visits they have per member, office visits just is lower in those locations as well. So not only are they using ER visits, they're not going to the doctor, the primary care providers. So the way services are being provided, the type of services that those members have, it's definitely different in these locations, and it's not the most efficient way of doing it. And maybe Mary Kay can provide some, I don't know, some information about what could be done about that. But I'll turn it to Rep. Nose for his question first.
This is so interesting. And for me as a policymaker, part of what I enjoy about coming to these meetings is I get to see how the things I'm trying to do at the state level when I pass laws and budgets impact, what we're all trying to do here. Isn't the story here that there's just not enough providers in Southeast Oregon? And so people go get care at the emergency room because we haven't figured out how to attract providers to live in that part of the world and provide care. I mean, that's to me what this is about.
That is,
I'm guessing.
That's quite possibly the case. I think definitely provider access, and some of the information I think we're talking about trying to get number of providers that are being utilized. Yeah, we can try to get the data that actually says
it'd be
exactly that.
Fascinating if we could figure out how to have an overlay of what the networks are available, okay, with the carriers that we have, and then figure out like, okay, carrier, can you figure out how to attract? I mean, because this is very anecdotal, okay, but like I had a tough conversation with a CEO at Bay Area Hospital, which is Southeast Coos Bay, okay? And the poor guy wanted to close a bunch of psychiatric beds because his nurses were getting harmed and the patients were staying longer and costing him more money than he could manage, okay? We figured something out, all right? But he's like, Rob, I tried for 3 years to recruit a psychiatrist. I think he said 3 years. And 2 months before he was able to secure the person to come, the man, and it was a guy, got another job somewhere. And so like he just couldn't, like, it's like he couldn't win for it. So to me, it's like that is a thing that if we can figure out how to do that, we can maybe change some of what we're seeing here. Because I make the assumption that most PEB members, you got to have a little bit on the ball to be a state employee, okay? They can, given access, okay, figure out how to not go to the emergency room for everything. I mean, maybe we need to change our copay a little bit, but like, I'm guessing they're doing that because we don't have the provider network.
Right. And you don't have access in a timely fashion to meet, individuals.
I mean, that's why I go to urgency care at Kaiser once in a while. Okay. But I'm here, I'm in the Northeast part of the state, where it's just like, well, okay, they can't see me and this is hurting or bleeding or infectious. I'm going to urgency care, that's what it's for.
And I would even say some of those longer days in hospital have a lot to do with what the discharge options are, right? I mean, people get in the hospital and they need a step down, and in some of those areas, those beds aren't available either, right? I mean, it's the whole sort of operational flow of patient needs, and then having the adequate infrastructure to meet those needs. And so I think, as you're pointing out, we either have to get very clever about how resources are delivered and accessible, understandable, and impactful for people so they trust them, which can be a combination of people on site and some hybrid resources, and having adequate beds and staffing. And that's the national U.S. healthcare problem right now. So it's not just Oregon, right?
Well, maybe we can solve it for the whole country.
There you go. Oregon first.
I want to note that for utilization, excuse me, for utilization of emergency departments, there's quite a lot of information in claims analysis for what the drivers are. This was my area of academic work before I left academia, and so I do not doubt that network adequacy is and perhaps the primary driver there. But if there are others, for example, if the majority are traumas or injuries from falling off a bridge that doesn't have an access,
that's
right?
a legitimate use, yeah. But
Mhm.
it just seems like an outlier relative to, and just again, what I know anecdotally, I just think that they're struggling with a provider network.
Yeah. Well, I have looked at this quite a bit as well, Dawn, and there's people that that's the only way they access behavioral health services, right? And so they're the most likely repeated users.
Oh,
because
yeah. Back to my psychiatrist.
Yeah, and then there are people who work and they need to take their kids who are sick to get care somewhere, and there's no daytime pediatric appointment slots or whatever, and you're going to take care of your kid. So you go. And I mean, there's certain different storylines, if you will, of drivers, and each requiring its own solution, of course. But I don't know, Dawn, if that lines up with your research, because that wasn't an academic study of mine. That's just more my career work.
No, right. The thrust of the work then is that for a population like the one that we have here, as Repnos was describing, the subsets, the sub-segmentation of those who are spending a lot of time in the emergency department gives us different interventions. Oh, look, here is a 100-mile radius with no psychologist, right? And that has a different solution than a bridge that doesn't have a barrier where people are falling off and hurting themselves and going to the emergency department with injury. So there's an opportunity there to focus our attention on network access that specifically meets the needs of the people who are in the ED all the time. Sean.
Yeah, really productive conversation. I look forward to more of it. And I think Representative Nose is onto something. I mean, on some level, there's not enough providers. Like, we got to figure out a system. And the only thing I would add, just to make matters worse, I guess, is that from my experience now working in the state fire marshal department, we have a lot of employees out there. It's been eye-opening how little internet connection there is in rural Oregon. Like it really doesn't take much to get off of I-5 and then you're out. And you can get some, and we've had to do some special purchasing of special networks to get our employees with enough network connection to be worth it. But for a video call with a doctor, that's a high bar for as well, literally with the bars. You would need a lot of bandwidth to make that happen. And there are huge swaths of Oregon that is not a great option. So we also cannot solve this, it seems to me, by just throwing that solution at it, which is a good solution. I don't want to lose it. I don't want to be like, let's not talk about virtual care ever again. It's not like that. It's just, I don't think that that's the silver bullet where it's like, well, that's the solution for rural Oregon.
Well, virtual care
that is one solution.
Would help, though.
It would help. Yeah, we should talk about it as part of the mix.
I'll take virtual care over ER visits.
What I'm saying is a lot of these communities cannot even get virtual care because they don't have enough bandwidth. So it's part of the solution, but I think it's a bigger conversation about how do we literally get people, providers, to some of these communities in a semi-permanent way, or make it easier to hire or something. I don't know what that looks like, but it's worth conversation because I don't think we can just throw one thing at it and be like, oh, it's virtual care solved, you know. So
But
that's
for a lot of behavioral health care, they do think virtual care works pretty well.
Yeah, if you have bandwidth. Yeah. Mm.
Yeah, yeah. I mean, all these topics, all these considerations. Yeah, it's like keep those in mind. What can we do have some potential options to help? Well, I don't know if it's gonna, to try to help solve, I don't know, solve the issues, but help ameliorate some of the issues. But yeah, just definitely keep that in mind. Just kind of quickly, the cost is different based on ER use cost and office visits. It's not really the way you want to see it for Northeast and Southeast. And then the screening rates, I think, again, Northeast, Southeast, the screening rates are a lot lower. Are they getting the care that they really need in this case? And these are normalized to the appropriate age ranges too. So it's not like just younger dependents, but they're normalized.
Yeah.
Andy, you had a question, comment?
Oh, I just want a comment when we were talking about how do we get providers into rural areas. And I think one of the things we kind of overlook, and it's hard to do money wise, is that we have schools here that do medicine and things that if we are maybe offering scholarships or funding for those individuals to go to school and then spend so many years in a rural area. And then we may already have that, but something like that might be worthwhile to look at.
Yeah, definitely. And hold that thought for a few slides later. Yeah, we do bring up items like that, and yeah, definitely. And we also have Gretchen Horton Dunbar, who's on the call from Mercer. I may call upon you if you're still on at that time to help talk about some of your knowledge about those things as we get to that point. Okay, so moving on to the next slide. Kind of looking at the conditions by regions, I think just really focusing, I think we talked about behavioral health, right? Again, Northeast, Southeast, rural Oregon, behavioral health care. The number of members who have those diagnoses and receiving services for them, much lower than the rest of Oregon. It's not necessarily that they don't have those issues. It made the stigma around those issues. And I think I've heard that tele-behavioral health helps with that stigma because you're not actually going physically and you can maybe just go in your car or a room and to talk away from others, but it is the diagnoses and the treatments are much lower compared to urban areas of the state. So that's a big thing. There's some the asthma in a couple locations is higher, and then I don't know if it's an outlier for the coast on obesity, but that's quite a bit higher there compared to the rest of it.
And Emery, did you just pick out for mental health the top 3, respiratory the top 2, and endocrine weight the top 2?
Yeah, these are kind of like the biggest ones. These are kind of the standard package of the types of essentially chronic conditions or diagnoses that we can pull. It's just kind of like the ones that yes, the standard ones, but it's ones that we've shown in utilization reporting in the past. But just wanted to highlight the different locations. So, the type of care that members need for, potentially are getting diagnosed with is definitely different. So that's something to consider, especially, in light of some of the preventive care, the low numbers of screenings and other things happening in the frontier locations. Okay, next slide. And, okay, so we have race and ethnicity data in our database now. So we'll be seeing more of these breakouts. We've done this as special looks in the past, but just kind of taking a look at the different races and ethnicities down there at the bottom. So AIAN, for those who don't know, they're Heritage Native Americans or American Indians, Alaskan Natives in this case, Asians, Black and African Americans, multiracial. It's based on what was in the data. If it was listed as multiracial, we just kind of listed as there, depending on whichever races that we didn't break out the biracial or multiracial. We just kind of lumped them together. not a political statement, just the way we did with the data. Not available. The Native Hawaiians, other Pacific Islanders, as well as whites, others, and then those who refused, as well as Hispanic Latinos. So we do have a lot of different race and ethnicities listed out here. I think generally, the urbans, the darker blue, and rural Oregon is the orange. The ones that definitely stand out to me, the Asian and the Black and African Americans, a lot fewer in the rural locations, and Native Americans, Native Hawaiians, I mean, a bit lower as well. But the rest of the races are typically about the same for rural Oregon in terms of split, about 27%, although the AIAN has a lot more in the rural areas. So I don't know. It's kind of interesting. I think I don't know if it's not surprising about the Asian and the Black African Americans being much more urban, but the types of members, the race and ethnicity of members, is definitely different by the different locations around the state. Okay, next slide. So, taking a look at the healthcare risk, so the risk relative to PEB average, as well as the efficiency, the cost of those services. So the risk of the member, relative risk of the member, is the line that's moving up and down, and then the relative cost of the services to provide healthcare services for the member is the bars. So with the risk, you can definitely see some bigger differences by the different races, ethnicities. The AIN, American Indian, Alaska Natives, have the highest risk, and this is age and gender. It's age and gender is built in, as well as the diagnoses in there. So they are 18% higher risk than PEB on average. White PEB members are the other that are above 1.0, they're 1.06. The other races and ethnicities are lower, with Asians being quite a bit lower, about 20% lower risk. Multiracial is actually about 20% as well as the Native Hawaiian, other Pacific Islanders, and Hispanic Latinos. So it's the types of PEB members and their race ethnicities. The risk is a bit different. There's a lot more that we could probably dive into it, and be interesting to see what we can glean from the data. But these are sorts of things that I think we definitely want the plans, the winning bidders, to look into and try to address, because the needs of the American Indian Alaska Natives, AIN, I mean, it's 18% higher than the PEB average. And trying to address that, I think, is very important. The cost of essentially how they're addressing it, basically, the multiracial and the whites are above 1.0. So they're getting more services, or a little bit more costly services, for the amount of risk that they have. So this is normalized to the risk. So essentially, and with the other races, they're below the 1.0, especially with, I think, taking a look at the Black and African American, they're getting their cost per risk is at 13% below PEB average. I've read stories about, studies about, essentially, are these members of other races getting the type of care? Are there concerns? Are there issues being heard by the provider? And are those services being provided by the provider? And based on this, it's interesting to see how much lower that the amount of services that Black and African Americans are getting in relation to PEB average, and that the whites are getting a bit more. White members getting a bit more. So, I think there's a lot more to be delved into here, but the inequities based on the race might be showing up in some of this information. So it's something that I think we'll want to look into, as well as have the plans address moving forward. Okay. All right. Moving on. and I know we have had a lot of discussion, and so I'll try to be a little bit quicker about this. The cost of care for these members by the different races and ethnicities. So we have the PMPM cost, so just the pure allowed cost, and then we have the risk of the members. I think what we want to point out is, and these are continuously enrolled PEB members, so members who have been in the PEB plan for essentially the last 5-6 years. Again, the AI, and they do have the highest risk, and the risk is increasing the most annually. The Native Hawaiians, other Pacific Islanders as well, their risk is increasing more. So their conditions or the amount of services that they need is getting higher, increasing a lot more than PEB average. So are they getting the care that's actually keeping their risk, that keeping them healthy? This data kind of hints that maybe it's not. And the cost of services for the AI and population is definitely quite a bit higher. So, in terms of out-of-pocket costs and the cost of services, it's going way up. There's it's just like we need to look into whether they're disproportionately being impacted by some of the what's happening in terms of their healthcare in this case. Okay. Any questions or comments before we move on? All right, next slide, please. Oh, Emily, go for it.
Yeah, sorry, I just put it in the chat
Okay.
that for Asian, just in general, because it's such a diverse group of ethnicities, it might be good to start disaggregating, even starting with like Southeast Asian and like pulling that out. The Vietnamese, the Hmong, the Thai that tend to be higher poverty rates than the East Asian, like Japanese and that kind of thing. So
yeah, and it would be great if we had that data. I guess to Bill's point, right now the data that we have does not have that. I think I'm trying to remember what the I can't recall with Oregon and the SOGI data. Well, the data that's trying to be collected. If it's going to be able to break it out to that point, we might be able to, but that's not what we currently have.
okay, I
Yeah,
know
Real
that's
D and SOGI. Yeah, Emily, you probably know more about Real D and its collection and time trajectory than others of us, but that the collection of that data is sort of growing now, but our data is by no means complete at this time for race, ethnicity, language, and disability, as well as sexual orientation and gender identity. So thank you for that.
Yeah, Emily, it's a really good point, and it speaks to the fact that like when we look at data in aggregate, we're losing nuance. And so moving from just looking at rural or urban to some of the populations that Emery went through is a huge step in the right direction, but it's not complete. For your comments, there's still work to do to look at the data in a more granular way.
Yeah, and even like for example, remembering the purpose of disaggregating and having a clearer picture. Like for example, cervical cancer, like Vietnamese women have the highest cervical cancer rates out of all the racial ethnic groups, higher than other Asian ethnic groups. So why is that? It's because they're working in nail salons, because it's a social determinant of health issue. It's because you don't have to have English to have that job, because they have a Vietnamese language test, that to become a nail salon, worker. And so just, we're not just trying to disaggregate data just for the sake of it. We're trying to get a clearer picture for the people who live in Oregon or work for Oregon. Not everybody under the sun, but the people that are here. What are those issues, those health issues for them? So.
Yeah, well said.
Yeah, unfortunately, I mean, the information we have is kind of monolithic rather than, broken out by the different populations in different countries and locations. So just kind of quickly on overall trend by urban, rural, and other locations. This is a little bit different from what data we had shown in the past. I think some of the cost issues, pressures in the urban areas are showing up here. Before, the rural areas were trending a lot higher, but now the urban areas are trending at or just slightly above the rural areas in terms of the cost and in case this in the risk as well. So this is a little bit interesting. The underlying cost of services is going up quite a bit in the urban locations, which you wouldn't like to see with competition, but that is, it's definitely a change from what we've seen in the last few years. Okay, next slide. Okay, so getting away from the hard numbers and like going to the member survey results, we provided picked out some quotes from the member survey. And this is talking about asking members about the vendors and how they're performing. And I won't read these, but I think if you go through these, a lot of them are about the cost, ability to get services, just finding providers, especially for like some of these rural areas and some of the issues that they're facing trying to getting services. So definitely take a look through some of this. I mean, I think it's across the board between behavioral health, primary physician services, RX. It's like just general services. The needs of the rural members here. They are large and they are impactful in this case. Okay, next slide. Okay, so some of the issues that we've heard, and this is by no means a comprehensive list, but some of the things that Mercer has heard and curated here. Rural areas not to Kaiser. It's like Umatilla, they don't have a Kaiser like product and Kaiser like cost sharing. So they do have more than choice, but they don't have the really low cost showing, especially Northeast. Access to providers in limited, we've been talking, those issues have been brought up on this call. Traditional alternative health workers are not in network or they're limited as well. Some of the data talking about, the congruence of providers with PEBB membership, it's definitely some big member issues around that have been brought up. Financial health of hospitals, I think Rep knows, that's health workforce supply, travel prices, out-of-state employees, there's a lot more out-of-state employees now with only access statewide. And what does PEBB want to do about that in the RFP? And one thing we've heard from, especially from the plant, value-based payments, quality metrics in areas with limited providers. It's just like trying to get those Oregon initiatives, Oregon focuses, trying to get that across is difficult in some of these locations. These are some of the things we heard. I don't know if there's other things that you might want to bring up before we move on to the next few slides that the board, that we have addressed.
Emery, just the issue of the out of state people, that comes up perennially. So I'm wondering if we could just go ahead when we get to that point, maybe at the retreat or just future meeting, where we can just break that out at this point. Like how many people are we talking? There's I've heard about the young people, the people going to college, that are still on the plan from their parents, right? And then there's certain types of employees, like sometimes there's university professors who do out of country, out of state classes every 6 months or something like that. And then there's, as you say, then there's been a hiring that certainly was kicked off during the pandemic of out of state employees who are permanently out of state. So it would be good to just get some demographics and how many people are we really talking about, so that we can kind of get our arms around the size of the problem when it comes to the new RFP.
Yeah, I think the number I heard for like what we might consider truly out of state, those who are maybe telehealth workers, or not telehealth, but teleworkers. I think it's 1,000, or it's 1,000 now. But I don't know, Cindy or anyone else from staff that might. Go ahead.
Yeah, this is Ollie. We can definitely get that number, Sean. It's definitely grown quite a bit, and we definitely hear from folks out of state, that they would really like a more competitive benefit to those that live in states. So it's something we should definitely look at.
Yeah.
Yeah, it feels like if there's 1,000 or more, that kind of feels like its own part of the plan. Anyway, okay, we can talk about that later. I'm just curious.
Yeah,
we do touch upon
it a little bit, but I think with the retreat, we'll want to address it a bit more. Emily, you have your hand raised.
Yeah, thanks. This was really awesome, this whole presentation and all the data. I just appreciate everybody's work, and the visuals. I was just going to add, for travel, transportation, challenges to access to care. When we developed the health equity policy priorities for the state of Oregon in about 2014, and I had this policy platform panel that I worked with, and we were trying to get them to be representative of the geographic diversity of the state. At that time, I was working with someone, I can't remember what his name was, but he was out of the public health division, and he was sharing these rural urban commuting area codes, these RUCA codes that census collects, and it shows like how people are commuting. And so we actually use those codes as we were trying to build up a representative advisory committee. And so like they have like a UA means primary flow within an urbanized area, but they have like metropolitan area high commuting where primary flow 30% or more to a UA. Then they have like micropolitan area core. And so anyways, and then like a rural thing. I'm just brainstorming here and just thinking that it might be interesting to explore those codes for the purpose of improving access to healthcare, like, future, bigger picture. So thanks.
Yeah, we'll have to look at it. Yeah, I'm not familiar with it, but we'll take a look into that. Okay, I know we've been having some really good discussions, and we're kind of, I don't know, running a little bit longer on what we expect. But next slide actually just kind of summarizes some of the things we talked about. So we'll just flash it up there real quick, but we'll move on to actually some potential opportunities, things to maybe look into or address in RFP in the next section. Okay, so if we can move a couple more slides, please. Okay, so this is talking about the network continuum, where you currently are. So you do have the asterisks, one for Kaiser, two for essentially Providence and Moda, the coordinated care, the coordinated care plans, and then you have statewide, which is a little bit less managed in this case. We do have 4 for PEBB in terms of number of plan offerings down there below, but we talk about the different ways you can get potentially more aggressive. And these are things to consider in the RFP in terms of the care management, provider options, and the plan offerings. It's not, they're kind of all interrelated, really, in terms of what you want to offer and how you might be able to leverage that offerings in terms of trying to get the best networks, try to get the best admin fees, and the care coordination in this case. But in terms of care management, most aggressive would be essentially a Kaiser type of plan. The moderately aggressive is what you have with Province Moda, and then statewide is least aggressive. It's like it's managed, but it's not like like a wildly open access. But it definitely has less management than some of the other plans. So the further left you move on the continuum, you do get more savings potential in this case. The care management aspect of it can be definitely tighter and save some money. The provider options, we discussed this a bit in the last retreat, but it's another issue to come up with, in terms of you do save more money the smaller network and more leverage you try to impart in terms of the type of network you have, the type of value-based payments you can have with those systems, as well as like just getting the financially connected, the connected systems. But you get hopefully better care coordination, care management in that case, and better hopefully savings in this case. But the more narrow the provider options, the more savings you might be able to achieve. And then down towards the plan offerings right now, giving PEB members a lot of options, especially in the urban areas. But the fewer that you have, and potentially one per plan type, you do start talking about, again, creating that leverage, or at least, you have fewer options, but you have the potential to save some money. And every dollar counts when we're talking about 3.4% limitations per year. So we don't have to decide this right now, but just kind of want to bring this out as something to think about, especially in light of the retreat that's coming up next month. Okay, next slide, please. So some areas where you can have some potential network enhancements, and we have different areas where it's like different types of potential opportunities, and this one we labeled network, but there's things that could be done, could be put in the RFP, or could be required of the plans to help with some of these issues. So network standards, adequacy, just trying to determine that and differentiating those network standards by urban and rural areas. We've started doing that with the behavioral health performance guarantees and standards, and applying that, for other types of providers. Things could be written into the RFP in this case. New patients, trying to deal with the ghost network type of issues, the networks that appear to be wide but don't have providers accepting. What types of things you can do in terms of setting like limits or requirements on providers having accepting new patients. With behavioral health, again, we are saying, we want to see what types, the number of providers accepting new patients, because it's no good to have a network where no one's accepting new patients, and that is quite frequently an issue. And I think we ran into that issue in, I think, the Hood River area with some pediatricians, very limited. I don't know if it's limited or the network did not have providers who were in network pediatricians. And so that was one of the concerns we heard from staff about and members in that case. Updating out network standards, tracking it, allowing single case agreements, and looking into that more, just kind of expanding the impact of those network standards or single case agreements in this case. RX benefits, I think we're going to maybe talk a little bit more about that in the retreat, but that was an issue that came up during Sarah Drake's presentation, and we're looking into information how far members have to travel for retail pharmacy, and finding out ways to address that. The BH services here, it's a lot of different types of BH services that some are being provided, but not necessarily all that are being provided. But traditional health workers, there's a lot of things there. That's part of the CL work group, and nod to the upcoming agenda item, but that's an issue that's trying to be addressed. But it's a lot of BH, just getting access to the BH providers, the congruent BH providers that dealing especially with the members who speak different languages, different races, understanding them, and just getting those access and the types of providers. What can be done in the RFP to ensure that these providers are being available, that they can be accessed. There's information about them, just make it easy for members to actually get it, and so that they don't have to go out and then get reimbursed for their payments. I mean, it's like paying a bunch of money in this case to get those services and then having to wait to get reimbursed is not the most ideal situation. So just making sure that there's integration with the plan in this case. Again, wait times and access standards for rural areas. And then this one on the right, PCPCH improvements, it's been in place for quite a bit, but and there's definitely a lot of tiers and a lot of help, but just what some of these other ways that PEB or the plans could help, trying to make sure that integrated behavioral health. I think this we've talked a bit. I think Christy talked a bit about this on her presentation on the behavioral health care coordination, care management, getting the integrated behavioral health providers in the primary care homes, just being able to have someone there if there is an urgent need or someone gets identified as having a behavioral health need. The traditional health workers as well. It's not just, it's navigation. There's navigation with some of these traditional health workers, community health workers, and just getting that as part of the PCPCHs and getting those PCPCHs up to like a 5-star designation, or even getting to 1 star, just getting those primary care homes or providers to become primary care homes, and health related social needs, HRSNs. And translation services. So these are some things that are potential for network enhancements. And with that, I know I talked a bit. I'll take a drink, but don't know if there's any questions or comments that people have before we move on to the next slide. Okay. So moving on. Provider directory and reporting best practices. I think this is something that PEB has been working on, but there are some opportunities, some best practices on these with especially, and they align with some NCQA network standards. So, these are some things that could be improved or should be potentially best practices in this case. So we do have some potential opportunities for Providence and Moda, as well as Providence, Moda, and Kaiser, based on the asterisks. So hospital affiliations, when we looked at the provider directories, it was there for Kaiser, but they were not there for Providence and Moda. So some of those hospital affiliations, as well as making sure, I think the provider locations and accepting new patients is on there. Accepting new patients, I think in terms of addressing and making sure they are up to date, I think that's a big thing. Not just that, hey, it may be there, but if it's from a year ago, it's not that useful if they're no longer accepting new patients. It's a little frustrating to call and then find out that they're not accepting. So making sure that it's accurate is definitely important, in addition to having it on the standards or on the websites. Enhancing the direct information. So whether the provider offers telehealth as well. So that's something that we didn't note was in the provider directory for all of the plans. Hours of operation, Kaiser does have that. Providence and Moda, I didn't really see that. So that sort of information would be helpful. In many cases, it's like Googling is an extra step, or Bing or whatever your search engine is. Ask Jeeves. It's an extra step, it's extra time. If you're on the website, hopefully you can see it and you have the phone number and all the information is right there for you. But just trying to get that information on the website and able for providers, for the members to look at, and making sure that it's accurate. Network reporting requirements, the types of locations in county level. I think, we've talked, again, behavioral health is kind of getting more towards that, just making sure it's there for all other providers as well, just trying to get that information to break it out between rural and urban and other frontier locations. And, this next one, taking a look at where there are issues in developing or having a development and management plan. if there are areas of deficiency, or just making sure that there is a plan in place to have all of these best practices to make sure the information's up to date, requiring that as part of the RFP. I think, if they're being held accountable to it, then it's more likely it's going to get done, and that it's going to be accurate. So having that as part of the RFP would be one, a potential option moving forward. Okay. Please interrupt me or ask questions if you have any. Next slide, please. Telehealth enhancements. Telehealth definitely can be very helpful. It can, you can add access, expand the provider access, increase the types of providers there in the third column. The network adequacy. It's ideally, it's like you could finding out the gaps and maybe temporarily, maybe not permanently, but temporarily addressing those gaps. We know there are issues with broadband, but every little bit helps, I think. You can try to supplement that PEB has been doing with telehealth vendors, especially for some of the rural areas or out of state. Payment innovation. So, VBP payments for access and utilization, kind of like creating that base and making sure that there's payments there to, for the services. And so that it's not just on a per service, that you actually have, telehealth providers who are potentially, know that PEB is an important client and important members, and getting that payment there so that they know they'll provide access to the PEB members in this case. And then the one there on the right, I think this is kind of like, again, a little bit longer term project, OHSU's Project Echo. So basically trying to help primary care coordinate with like getting the specialty services coordination with the primary care, and just like kind of getting in one place rather than having the member have to go to the specialist, getting the primary care provider to kind of to have that better, I guess, base of information, better technology to address the overall care needs of the member. So don't know exactly what the plans are doing to to address or to help providers participate in this project, but it's one area that could be looked into, and to partner. PEB could partner with different initiatives across the state to increase and improve the care for providers for the members. And then the bottom, I think, the note, telehealth can fill gaps, but based on the survey, PEB members do prefer in-person care. So while this is important and can help fill those gaps, increasing the access to actual in-person providers, and I think the next slides do talk a little bit about that, improving the workforce and provider access. PEB members do prefer in-person care. So this is important to consider. It's not just telehealth, don't throw in telehealth and call it good. You have to try to address in-person and get those providers, true provider in-person access for the members in this case. Okay.
Emery,
yes.
Andrew, I don't know. Are you aware of any programs or experiments out there? I mean, I haven't heard of any in Oregon, but maybe somewhere in your network, your whole portfolio, of a hybrid approach where there might be a rural clinic that has, some person there that's in person, a nurse, let's just say, who is helping essentially connect, maybe like in a room, but they have all of the technology figured out to where they are then communicating directly with a doctor online, using, presumably the clinic would be well wired to be able to do that. So it's like if you weren't able to have a reliable connection, you could go to this clinic, which is quite close because there's more of them, because you don't need a doctor in every one. When they're connecting with a an established network of doctors, and they're kind of like continuously going through all these rooms.
Yeah.
Which is literally a room, and there is a person there who's like, can you do this kind of exam and then send me notes, that sort of thing. Are you aware of anything like that? Is trying to split the difference to
Yes.
kind of solve the
Yeah.
rural situation?
There is, and I know provide additional detail on this. And hopefully I don't contradict anything she says. I've definitely heard of essentially telehealth kiosks where you are connected in that case and you can talk. And Gretchen, did you want to provide some additional information?
Sure. In addition to the kiosks, which I believe Lane County on the Medicaid side has tried, they also tried a hybrid model very similar to that, where a member could come to an established office, even if their provider wasn't at that office, and use their technology to have an appointment. And part of the challenge was, how is that paid for and billed? But they were testing that. I'm not sure where that landed, but I think that is a potential opportunity.
Yeah, and Sean, there are companies that provide rooms on site in their workplace, that give people the technology infrastructure, and then the link with the provider who's remote is the clinical interaction. So the primary concerns, of course, there are, the technology and the privacy. And I just have to say, I was doing early remote healthcare a long time ago, and we used to have to go to educational service centers in order to link people with physicians in urban areas for rural folks in Alaska, and rural Washington was the project I was working on at the time. But the technology being present is obviously key, but the actual technical the clinical interaction is kind of independent of that. So the place doesn't have to be able to bill necessarily.
Yeah. So we can definitely, I think those are some things that, we can definitely explore, getting that access. It is still an issue. You're not going to have a kiosk in the middle of like a national forest as the firefighters are like trying to put out a wildfire, but, maybe there might be some rural locations that it might make some sense. Emily.
Yeah, I love that question, Sean. Thank you for asking that. And it's amazing to hear that Lane County's actually already tried some of that with the Medicaid population. And then I just wanted to add, in the similar spirit, but centered on equity and providing culturally appropriate, linguistically appropriate care goals that we have. We have such a large, I think I brought this up in a previous meeting, we have a large Marshallese population. I think it's the third most spoken language in Salem School District. And then, some of our Pacific Islander Marshallese physicians are very limited in the United States and are, I understand, in Arkansas. And so there's a lot of communication that actually goes back and forth between Oregon and Arkansas, for, in the name of better health, to connect with those rare Pacific Islander physicians or Marshallese physicians, better not quote me about which ethnic group. But then in the same vein, I also know one of the few Hmong family practice physicians in the United States who's in Minnesota, which has a really large Hmong population. So I'm just, thinking about equity goals, and thinking about our goals to provide more culturally and linguistically appropriate services, and just like, could we develop a hybrid model or support hybrid models, in this way? So just wanted to add that or ask that.
Yeah. I think that definitely things to consider. I don't know if it's, parsing out with the traditional health workers and just making sure that those are being covered, and the types of languages and types of, just the diverse number of workers and languages spoken and stuff like that. So that, there is some sort of connection, and just making sure members who might not be in urban areas or whatever are able to connect. It's like, I guess, let's try to figure out potential ways to address it, or at least ask the questions, right? What can you do to do this, and put that as part of the RFP. So we'll definitely take note of it, but remind us or be part of the RFP writing discussion, so that we don't forget it as we go on. Okay, I know we only have a few minutes left, so we'll just move on to the next slide. Okay, so provider payments and plan performance. So some of the things I think we're talking about trying to increase number of providers in various locations. Provider payments, I think the second bullet, behavioral health provider relocation assistance and sign-on bonuses. Having plans, develop strategies to cover travel for providers to rural areas. Maybe they won't live there permanently, but at least having them come out and creating like essentially pop-up clinics. I think it worked pretty well for vision. So, what can we do for primary care, behavioral health, and other issues there? It's not going to permanently solve the situation, but it might help alleviate some of the areas. Performance guarantees on specific health concerns. I mean, I think there's a lot of disparities, right? There's a lot of differences in how healthcare is provided, and having trying to get the plans to consider each of these different locations and not have it just entire across the state. It's like, what are you doing in these locations? What are the guarantees that you are agreeing to address in those areas? Payments for rural locations, network utilization, trying to increase payments for in-network to have fewer out-of-network. It's alleviate some of the concerns around billing and things like that. I think on a Society of Actuaries call, they talked about behavioral health. A lot of people, providers who end up having clawbacks. Small providers, they don't have money to do the clawbacks, right? If you create a value-based payment, capitation payment that guarantees access and services, it's an easier way of dealing with that, to pay the providers rather than having them bill every single visit and then potentially dealing with other issues if something's not billed correctly. So maybe adding value-based payment arrangement and other ways to attract and retain the rural behavioral health providers. And again, improvement grants payments to improve medical homes, to improve the care and quality of services in some of these rural locations or other places around the state. So those are some things that could be, potentially addressed or included. Next slide talks about workforce and ways PEB could partner. I think developing partnerships and talking about student loan forgiveness towards Andy's point, kind of waiving tuitions for rural practice commitments, kind of creating some of those programs where it's like, if you're going to, you have a lot of, you have a lot of loans you have based on coming out of medical school, but hey, if PEBS help waives pays for it, for a member who's going to be in a frontier area or a rural location, and then help develop their set up their practice, that might be more impactful. It's like, for the amount of money you actually get a provider who's like there and potentially dedicated and part of the network in this case. Curriculum programs, more trainings, and then this workforce, again, retention plan, a plan to try to develop and retain more providers in the areas of need. It's like not just the network, but like what are you doing to address the issues with the providers? And this doesn't have to necessarily just be for medical. I think dental and vision have had those issues, so it could be across all of the plans in this case. But some ways that PEB could potentially partner with OHA or other schools or organizations across Oregon to help increase the workforce, which it's not going to be instantaneous, but we are talking longer term, and we are talking about members who are around for quite a bit, multiple years. So whatever can be done, it's going to help eventually. And then next slide, just not forgetting
So,
about them. Go ahead.
Comment from Ali.
Yeah, go for it.
Yeah, thanks, Emery. Yeah, I just wanted to make a comment on that. There's several initiatives ongoing in OHA around workforce development, but I think just from broad OHA, they've made a lot of headway in areas of cost containment, and as well as coverage. I think our state coverage numbers are higher than they've ever been. I think the real push right now is access, number of providers around the state, adequate network adequacy. I think those are the things that I'm hearing, within the last couple of months that are going to really be the next target areas of focus for the agency, and as well as this upcoming legislative session. So just wanted to add that. Thank you.
Andy, did you want to make a comment?
Nope, I was just excited. So I was like, hey, here I am.
Okay, just want to make sure. Okay. Yeah, so definitely, longer term projects, but, it's things that could be written to the RFP and to address in the future, to help alleviate the issues over time. And not just for PEBB, right? It's for the rest of Oregon as well. Okay.
So
go ahead.
I'll just add this as a side. It's probably a bridge too far, but what the heck? I'll mention it when you were talking about, value-based payments, that sort of thing. And so let me drive one issue that I'm driving in, right, is this issue about, all this paperwork that physicians and physicians groups need to do in the hospitals. And of course they all have to do that, but in rural areas, they don't have the resources to go chasing down such and such bill and whatever. And we have an access problem, and we just saw previously it's more expensive anyway. And okay. So when you add all that together, it seems to me that, if I was like emperor and could like make a whole bunch of things happen, there could be a partnership between us and some other purchasers. And I think it would be simpler, more predictable, and cheaper in the long run that we all just basically take however many members we've got, divide by a number, and be like, here's a blanket amount of money to just keep your hospital open. And we all kind of split the bill. And then they're like, it's basically a utility essentially. And they get a salary, like they get a predictable salary. They don't have to do all the fussy paperwork and whatever. They'll probably still have to do some for federal purposes and this and that. And we'll probably have some basic metrics or whatever, but the billing thing and like the code, and it has to be this, it's like irrelevant. It's just, we're assuming that we all have this number of people in the area between a bunch of big purchasers, and we're all just paying for the behavioral health clinic and the hospital and the primary care clinic in the end. And it would require like a joint partnership thing, which is probably a bridge too far. But anyway, I'm just mentioning it. I mean, a lot of these hospitals are, whatever they're called, access hospitals anyway. So they already have special exemptions for a bunch of stuff anyway. So it's like, why not just go with it and we'll just pay for it together, and just, reasonable payment, reasonable salary. Some physicians might be drawn to it because they don't want to drown the rest of their life in paperwork. And it's like a little simpler model, like back when you used to practice medicine instead of paperwork, and some of them might be drawn to that, right? So anyway, I'm just throwing it out there. It's probably not in the cards for this RFP because it would take so much like partnership development stuff and probably some legislation. But anyway, for what it's worth.
Yeah. Yeah. I mean, I've heard that. I think I don't know, Ollie, it's like maybe a former board member he may have had similar type of ideas, and like, I don't know, legislators as well. But yeah, it's a big idea. I think that's, whether it can be implemented or not. I don't know. It'd be interesting to try to address. It is a big thing. We have, I think, a lot of different parties that are interested in this call right now, from all portions that might actually be able to help implement that sort of an idea. But I don't think we're going to be able to handle it in the 2 minutes or minus 2 minutes we have left. Okay, so moving on to the next slide. So member experience. So I think, I don't know, to me, the member experience, the slide we had before with some of the quotes, I mean, just highlights some of the issues. It doesn't, to me, it really hits if you see and hear what the members have to say. So, these surveys, getting that information out, grievances and appeals, where are the members having issues? Like, are you tracking it? Are you understanding what are you doing to address these? The performance, the plan, improvement plans, based on what's actually the issues coming up that members and are facing. So making sure that that's in the RFP, and part of the guarantees or requirements for the plans to address. So these are other things to help address the members, and segmenting that by the different locations, by different types of members, race, ethnicity, location, whatever, whatnot, other social determinants. That's being able to understand that and knowing what the issues are, then allows you to actually create solutions, hopefully, to address those issues. Okay. This next slide says discussion, but I think we'll actually skip the discussion because we've had a lot of it, and I think it was very important. So, there's different, we just kind of listed some of these topics by these different areas. I think just we'll hold this for the retreat and come back to it. But, different areas to consider and what potentially where PEB might want to really address and focus on in the RFP, some of the really, really big important things, because there's a lot of issues. Unfortunately, writing 500 questions is going to give Rep. Nost heartburn for him to score, but
I'm not doing it. I'm a non-voting member of this thing. I had that hell 10 years ago. I remember it very well.
So we'll make it 200 questions instead of 500 questions, but
Jesus.
just like cutting it down. So it's the plans are actually able to make relevant.
We just do that to
quit.
taunt you.
I resign. I resign.
Yeah.
Yeah. So we'll focus and get hear you.
Emery, you were there 10 years ago,
I was
making me endure this.
I was. Yeah.
How did I forget that? I mean, I know you've been around this a long time.
Yeah. Well,
I did have a really quick question because I
Yes.
need to leave a little early today. The retreat is when again?
Yeah, actually, it's November 12th. Ali, why don't you talk about the retreat
And it's
real
in
quick?
person, right? Like I need to come to Salem.
Yeah, it is. This is Ollie. It's November 12th, Tuesday, 9:30 to 2:30, I believe. 2:33 is, correct me if I'm wrong, Rose.
I'm planning on being there.
Yeah, there will be a virtual option, but we are really hoping that
I'm coming.
everyone can attend.
Yep.
I also wanted to mention that travel costs are reimbursed and lunch will be provided. Also, in just staying consistent with previous years, we're asking that carrier representatives not attend the PEB board retreat in person or virtually. This is really just to allow the board to focus on their strategic discussions, and there will actually be a recording of the meeting available after the meeting and posted to the PEB website if folks are interested in that. So thanks, Emery.
Yeah. And we'll go to the slide talking about the retreat. But, I think, Sean, really to your point, if you really want to reform the system, it does require a majority of the interested parties to be actually invested and part of it. You're not going to get, PEB is big, but it's not really that big. So getting other interested parties, especially with trying to increase, these bigger issues. So whatever PEB can do, along with OHA and other, entities, to really improve care across Oregon in this case. So just something to keep in mind. Okay,
well, Sean, maybe you can apply. Maybe you can apply for, be the director of OHA someday. Dr. Hothy's not going to do it for forever.
No.
Yes. Yes.
Okay, so actually just moving on in a couple slides down. It's just, yeah. So just the tentative agenda for the retreat. So member experience is going to be key focus. We'll follow up on all these other topics, talk about value-based and network contracting, although I don't think we'll necessarily solve Sean's issue there. And then we'll also want to talk about the board responsibilities on drafting, approving, and scoring of the RFP, who might want to be part of it, the expectations, and the timeline and other things, the needs that Mercer and staff is going to have of the board in this case. We also do want to talk about the proposed approach for the 26 renewal, because we are, this is a big project. There's going to be a lot of work. What we're going to do for 26, let's have a discussion about that, because it is kind of a transition, I don't know if transition year, but it's an interim year in this case. And then just drafting RFP is underway. We are starting on it, and we'll talk a little bit more about it in the retreat. So that's upcoming. I don't know, Dawn, if you.
So Dawn had to step.
Dawn.
Dawn
Okay.
stepped away for a meeting, and we are going to take a 10-minute break. Was there anything else you wanted to say about this section, Emery?
No, I was just going to see if there's anything else that you want to talk about about the retreat in addition to what Ollie had to say, but that was it.
Well, for sure, just underscoring the importance of showing up in person. I think Rob is going to show up to make sure he doesn't get assigned the RFP. That's what I'm hearing. But it's great that folks are planning to come in person. Was there anything else you wanted to say about it, Ollie?
No, that was it. Thanks, Siobhan.
Okay. All right. We're going to take a 10-minute break. We should all plan to be back at 11:30. Thank you. All right, welcome back, everyone. Christy, are you here?
I am here.
Okay, great. We have you leading on the CIAO Summer Research Group. So I'm going to turn it over to you.
Great. Thank you so much. So if we can move on to the first slide here. So today I am going to share first an update on our doula benefit, which you may all know, the PEBB board approved during the last renewal cycle. Oops, sorry, just seeing if I can get the slide moved forward. Thank you. Great. And so, this work came from 2 summers ago. The CIAO Summer Work Group research topic was doula benefit. And our group really looked at coverage across the United States in Medicaid plans as well as commercial plans. And then really our focus too was on the doula benefit that's currently being offered through the Oregon Health Plan. The state of Oregon does have a certification process that includes education and training, as well as an application process to become part of the Traditional Health Worker Registry. I want to recognize this as a brand new benefit. We are all really excited about it. The carriers are excited about it. I know the board is excited about offering it, and I know PEB members are going to be excited about it. And also want to recognize that many commercial plans don't offer coverage for doulas, especially in the way that is best practice as far as not having a reimbursement model where the member would have to pay out of pocket and then be reimbursed. And that's typically what we're finding in commercial plans thus far across the US. So very exciting. So the coverage that was approved is this 8 visits being reimbursed plus the birth delivery visit with a global fee. I'm just going to kind of talk through, I guess, how each of the carriers have kind of taken a little bit of a different approach on how to administer this benefit. As you all are familiar, with medical providers, behavioral health providers, right? We have in-network and out-of-network providers, and their in-network providers are contracted with. Because doulas are newer, currently the plans are not having a doula network in kind of the traditional sense of that word or contracts in place for the first rollout of this benefit starting 1/1/25. With that said, there may be a path forward in future iterations of this benefit. We have had a few conversations with NCQA on what that might look like in some of these pieces. So I just wanted to say that's kind of this first iteration. However, in our work group, it really was talking through the importance of having education training. The certification process that Oregon Health Authority has in place is such a benefit. And because this benefit is being offered through the Oregon Health Plans, there is this kind of process already in place. With that said, though, there are some different stipulations with the carriers of approaching this in different ways to roll out the benefit. One of the things we've asked is for carriers to direct members to the Oregon Health Authority's Traditional Health Worker Registry, which does list doulas in there. MODA and Providence have said that they are able to direct members to the registry as a starting point for finding a doula that has that education and training. Kaiser has said that due to compliance issues, they are not able to do that. And they would just have basic information on the website about the doula benefit and then be on their own to really locate a doula. As far as the requirements for doulas to submit a claim, Kaiser and Providence are kind of taking a more open approach where having the provider would submit with an MPI and a TIN. And this would allow for really any provider that has an MPI and a TIN to submit a claim for reimbursement without any indication of, again, training, certification, background. MODA is really, I think, aligning with the intent of the benefit, where requiring an Oregon Medicaid ID means that that doula does need to be part of the traditional health worker registry and through that certified doula process. What this does mean, though, is with out-of-state member coverage, that for Kaiser and Providence, again, because they're taking more of this open approach where really anyone can submit a reimbursement with an MPI and a TIN, it does allow for out-of-state coverage for doulas. Again, kind of where MODA is going with aligning with the Oregon Traditional Health Worker Directory and having that certification. Obviously, that's not available out of state, but there are virtual avenues for somebody who wanted to use a doula, that if that doula, as part of the Oregon State Registry, offered virtual services, that would be available. And then finally, just in the reimbursements, wanting to share that for MODA and Providence, they are doing reimbursements based on allowed amounts or billed charges, whichever is less. They have also provided, or will be providing in Providence's case for the 1/1/25, kind of a guidelines for the doulas to submit reimbursement, along with codes that they should be using and what the benefit is. Kaiser has a different approach, which is using billed charges, and this will be processed through a third-party vendor. For doulas that are needing assistance in submitting a claim, they're directed to the Kaiser provider website and navigating that in order to be able to submit reimbursement. Again, we're really excited about this benefit, and just wanted to make sure we brought back to the board some kind of different approaches, and we'll be continuing to work in future in the plan years ahead on evolving the benefit as well. So any questions on this? All right. So now I'm going to switch to our next topic, which is to provide you with an update on this most recent summer's CIAO work group. And so we focused on traditional health worker types that are outside of doulas. And you can see here there's 5 of them. Some of them are currently being used more than others within the Oregon Health Plan. Community health workers is one of them, that there's quite a bit of them already in Oregon. Peer support specialists actually are already covered by some of the carriers, and they are really integrated into a lot of behavioral health delivery care. Care delivery teams, and oftentimes are in maybe residential facilities, intensive outpatient programs where somebody's matched with a peer support specialist. There's also peer wellness specialists, personal health navigators. There are less of those currently in Oregon. And then there is a newly created tribal traditional health worker that is, as far as what that kind of, persons and groups kind of approach and how they're going to be integrated and working with different communities is still in process and being worked on and led by the tribes. And so as we move to the next slide, so what did the summer research group do? And I guess, first of all, why did we kind of look at traditional health workers? Well, as I was listening to Emery's conversation before and the questions everyone was asking in this wonderful discussion, is that oftentimes traditional health workers can bridge that gap, and especially in communities, in rural communities, and communities of different cultures, demographics. And so it was a perfect segue and makes a lot of sense for PEBB and OEB to be looking at traditional health workers. We know that traditional health workers oftentimes are living in the communities they're serving. They oftentimes have similar lived experiences, socioeconomic status, cultural backgrounds, languages, all of those components, which the research shows improves health outcomes can very much improve access to care. As I was looking at some of those numbers in different communities, I also sometimes think that maybe there's distrust of the medical community, a misunderstanding of medical community and where do I go to get care. And oftentimes that's where a traditional health worker can really be that bridge to help that person get connected to the right care at the right time. And then as you can see here, there's many other reasons that, researching and looking and exploring more into traditional healthcare worker coverage makes sense for PEBB. So the topics that how we started this process is here on the right. First of all, just some education about what are traditional health workers, what are the different certifications and requirements. We did ask the carriers to kind of present on currently what are they doing, again, mostly through their CCOs and working with, through Oregon Health Plan. We also then invited, and I just, Lily Sintum from Oregon Health Authority, and her team was such a great addition, and appreciate their time and kind of just telling us, giving us updates and learnings of how Oregon's current Medicaid integration of traditional health workers is going, and they also were the ones who were able to provide so much data about the numbers of them in the registry, and again, best practices and learnings. And then we really dove in as a group talking about different considerations of implementation. Again, talking about best practices, some of the challenges that have come up. And so we continue to have some open discussions about next steps and paths forward. So as we move to the next slide, just one thing I wanted to have in here, I'm not going to go over this in great detail, but community health worker is one of the ones, types of a traditional health worker, again, that has kind of a farther reaching scope than some of the others, and oftentimes can serve as a coordinator, a navigator, an advocate, and again, really that trusted person. And so recognizing that there really are a lot of different roles that a community health worker can play, and the positive impacts that person has is well documented in the research. So if we move to the next slide, the other thing we've really looked at is also equity for traditional health workers, and looking at the payment models and what makes sense, that if this benefit was to be approved by the boards, then what would that look like? And so the Oregon Traditional Health Worker Commission did have some payment model recommendations. A couple things to highlight here is that really that payment model needs to be sustainable. Currently, a lot of traditional health workers are actually in with community-based organizations, and a lot of times they're funded through grants, pilot programs, braided or blended funding. I mean, really trying to figure out how best to fund that. But oftentimes they are within CBOs within the communities. And a couple other things to keep in mind in this kind of sustainable payment models, recognizing that oftentimes a traditional health worker has other things outside of that 15 or 30 minutes they might be on a phone or meeting with somebody in person, that a typical like fee-for-service model is not necessarily going to capture all of those other pieces that they're doing as part of delivering care. Also, traditional health workers are to practice at the top of their certification. And again, this is where kind of looking at alternative payment models makes a lot of sense and really can support the better scope of their practice. As I said, often, traditional health workers oftentimes are within the communities that they serve. They're in these community-based organizations. And so just recognizing that there is expertise outside of the health systems within these CBOs and within the traditional health workers. And so really leveraging that expertise and either hiring directly or contracting through community-based organizations. And then lastly, just in these payment models, recognizing that traditional health workers are part of a long-term strategy to reduce inequities, to address social determinants of health, and just recognizing it's a long-term goal and objective within the strategies. Moving to the next slide. So of course, along the way, we've come up against some challenges, and this is typical, obviously, when we're looking at new benefits and integrating, I would say different provider types within our health systems. And I've touched on most of these already, but one of the main things, and we ran into this a little bit with doulas as well, is that we don't credential traditional health workers. And these types of traditional health workers we talked about this past summer outside of doulas are also a little bit different because doulas can bill directly to the health plans and have their own MPI and get their own Oregon Medicaid ID. Traditional health workers actually bill under a rendering provider, so they would not be credentialed. And again, so this is kind of where a fee-for-service model doesn't really work well for these types of traditional health workers. Again, capturing all that goes into the scope of what they do, and doing it that way is just inequitable and has an administrative burden. We did also find out, there isn't a whole lot of integration of traditional health workers currently within the clinical care teams. There are some clinics that are doing this really well, but in general, because traditional health workers oftentimes are in these community-based organizations, they don't have access to the electronic health records. They aren't able to make notes, and it's so important for the clinical team to know that there is a traditional health worker, a CHW, that is providing support to that member, and it's such a critical part of the care delivery. And it's important for the traditional health worker to know who the clinical care team is and to be, for referring and to know really what, what kind of experience that person is having so that the traditional health worker can support. I already touched on the third one and really the fourth one. As I said, fee-for-service payment models really are administratively burdensome and don't really work well for service delivery to capture what the THWs truly do. So moving on to my next slide, please. All right, so we're kind of at next steps on this project. We have had some conversations with carriers and asking some questions. Again, one of the biggest ones is if value-based payments makes the most sense moving forward as a way to reimburse traditional health workers and incentivize clinics for incorporating traditional health workers into their care delivery. And I think we've pretty much gotten a thumbs up on that makes the most sense from the carriers. We currently are exploring which clinics currently have traditional health workers integrated. And again, these are mostly CCOs across the state, so that we can kind of see what is the current kind of integration. And then on top of that, we're hoping we can maybe overlay some PEBB members in those clinics, just again, to see what a current impact might be, and to identify areas where support would be needed to help clinics integrate traditional health workers into their care delivery. And the other thing we've kind of posed to the carriers and to the group just to kind of mull over and to think about is having a liaison position. This is something that's required for Oregon Medicaid. The carriers, if they have a CCO, they do need to have a THW liaison. I will say they are a wealth of information, and they also participated in the summer research group, and many thanks also to them because they gave us some really great insights. But also having a position specifically for PEBB and OEB that would help support integration, help clinics that are not familiar with traditional health workers, kind of educating of what the benefits are, how you would integrate, again, reimbursements, and also be a resource for traditional health workers to get connected to clinics and for members. And then finally, we're still working on the CIAL recommendation. The CIAL group will be convening in sometime in November and December, really to discuss more about covering traditional health workers, and we'll be formulating a recommendation to bring forward to each of the boards.
All right. Well, thank you so much, Christy. And also just want to thank Andy Fultz and Greg Klauser for participating on the CO work group. Sean, do you have questions? I saw you pop on.
You know me so well. I have one question. Your bullet point that said went into the challenges, what the carriers that will not credential traditional health workers. What does that mean? Like, I guess I thought in my mind there was kind of a state, at least for some of them, there was kind of a state credential for some types, right? Is that true? Or we're asking each of the carrier to have their own credentialing system? Like, what do we mean there?
So I've learned a lot about this in the past couple of weeks. So forgive me as I will share my my learnings. Is that and this came up particularly with doulas. So doulas can bill directly to health plans, and but they are, because of their provider type and they're rather new, credentialing of doulas right now, like the plans say, they're unable to do. However, we are having conversations with NCQA because oftentimes, so the NCQA accreditation is part of, they oversee the quality and oversight of credentialing of providers, which is such an important component, right? To make sure we have providers that are licensed, they don't have judgments against them, or are keeping up on their continuing education, and all of those components is part of credentialing. My understanding for provider credentialing of like a MD or behavioral health is it's very extensive, 50 pages, huge process that is very cumbersome for the health plans and for the provider. We did find out from NCQA that there is another pathway that's possible for a provider type like a doula, that in states that have certifications in place, there are some ways to have a kind of streamlined credentialing process, and that we'll be exploring that in the year to come. And I think there is, again, some administrative burden to the health plan and to the doula themselves, but it seems like it can possibly be a streamlined process. Now, for these other traditional health workers that cannot bill directly, my understanding is they can't be credentialed because they do have to bill or provide services under a rendering provider. And so I don't think a future state of those other traditional health workers would be being credentialed just because of the way they are set up within the state of Oregon to have to be part of a rendering provider. So like they have to be part of care delivery of an MD or a nurse or another credentialed provider, if that makes sense.
All right. Thanks, Christy. Emily, it looks like you have a question too. Go ahead.
Oh yeah, thank you, Christy. I actually got a chance to hop into that summer group as well, so it was my first experience. So I learned a lot about like the carrier perspective on doulas and that kind of thing. I also added in the chat, in case it's helpful, some info from our OHA website on how to become a traditional health worker. I don't know as much about the credentialing and everything, so so that was helpful to hear. And then I just wanted to add, I've been in conversations a lot lately in our People of Color Employee Resource Group, like in Union World, the caucuses. People are asking about death doulas or end of life doulas, and I know that that's different from the birth doulas that that we're talking about, that OHA's current traditional health worker program, covers. It's a focus on birth doulas. But I just wanted to like flag that seems to be an emerging issue and interest of many of our members. Many of us have had family members pass away or, really sick, I think, since COVID, or people having long COVID, or, we've talked about that in previous board meetings. And so, yeah, these end of life doulas, death doulas, seem to be of strong interest. I mean, anecdotal information. I don't know if anybody has done a survey or anything, but yeah, so just wanted to flag that as maybe a future thing to explore.
Thanks, Emily. Yeah, we can bring that back for our health equity work group to do a deeper dive into that.
Great.
All right.
Thanks.
Thank you, and thank you for that presentation. And I know we have Bill Gropp with us from the OEB board. He's the CIAO chair, and he is going to be talking with us more about that work group. And I believe Glenn Bailey may also be joining him as part of this discussion. So Bill, I'm going to turn it over to you.
All right. Thanks for the time, everybody. Just a little bit of background. I've been on the OEB board for this is my 8th year on the OEB board. I'm the current chair of that board. I've been on CIAO for, I think, 7 years, maybe not all officially, but I've been there for 7 years. And last year and this year, I'm the current chair of the CIAO work group as well. And I wanted to give you a little history on the CIAO and some proposed updates and changes that we would like to make to the CIAO based on where we've been working the last year and a half or so to make it more accessible to both boards and valuable to both boards, actually. So first, though, I'll just do some academic rigor and fully admit to stealing the next 6 slides from a Mercer presentation. And then we'll get into the history of it. So just talking about it just in general, what we're trying to do here. From the CIAO perspective, we have basically 3 major stakeholders that we like to look at. And when we're doing evaluations on programs and things that are going on in the healthcare environment, the first one is the employee, of course, which is our major stakeholder. But what we discover is that the 3 primary goals of each of the stakeholders are pretty much the same: accessibility, affordability, and accountability. From the employee's point of view, we're looking for that accessibility to healthcare and affordability. And of course, we want responsible and good quality healthcare with accountability. Next slide, please. With the employer, our next major stakeholder, they're also interested in the same thing: accessibility with increased role, affordability for their budgets as well as their employee benefits to make sure that their employees are achieving healthcare goals, and of course accountability that everything is being done efficiently. There is fiduciary responsibilities on how the money is being spent and that everyone is getting the access that they need. Next slide, please. And then our vendors, or our healthcare providers, also have the same goals with accessibility, affordability, and they want to be accountable for their outcomes to ensure that they're giving the most efficient plans possible. And then our non-big providers, which are our mental health providers, our weight management programs, all of our additional programs that we contract with, also are in our vendor pool, and we do those kind of accountability and monitoring as well. Next slide, please. All right, so the way we're doing is that we all are bringing back along with an equity component here. And of course, our primary goal is that we do provide equity to all of our members through all of these goals that each stakeholder group wants. And we want to make sure that everyone is getting the maximum benefits and the maximum health care that the system can provide. Next slide, please. So currently the CIAO is between our clinical programs and our OEB board, where we kind of look at it in more detail. So we're doing the same kind of investigations as the board level work is doing for each year that they're doing renewing, and all of the programs that we want to offer or improve or make more efficient, or even eliminate if they're not being efficient. But what the CIAO committee does is we take it several levels deeper. We get into the deep data, the evaluation metrics, how things are being controlled and reported. We do that large amount of deep dive work and then report back to the OEB board on the recommendations that we prefer to see based on that data with some explanation. And I also point out that even when we're just doing the work, we always report back to the board what the work of the CL did that month and where it's going and what our drives and goals are for the upcoming time frame. So we're reporting back to the board all the time, and then at times when we're getting into the renewals, we do give recommendations on our clinical programs based on data and give short summary reviews on how we can achieve those recommendations, how we come to those conclusions. Next slide, please. Okay, so now reporting back to the board, we have two goals. One is the clinical oversight, where we're looking at that financial and clinical data to drive engagement, post-implementation oversight. What is our return on investments, right? Are we getting good value for our employees, for all of our stakeholders in what we're doing, and how it should be adjusted, or should it be continued, or should it be discontinued? Also, we look at clinical strategies, identifying opportunities with the dive into the data, access medical advances. We look forward to seeing things that are coming into the future that might affect how we provide healthcare or modernize the healthcare, or opportunities for integrating technology into our healthcare delivery systems. And then we give recommendations on clinical directions for the upcoming renewal. Next slide, please. All right, our responsibilities are to review, select, and evaluate the measurements for those return on investments on how we're providing healthcare system or healthcare goals to our stakeholders. We evaluate proposed health benefit program changes, either provided or recommended by our staff, Mercer, or any of our carriers. For example, we did the doula work and the GLP-1 work 2 summers ago, and the traditional healthcare workers that we just talked about this last summer with our subcommittees. And we review performances of our OEB health improvement programs, and then give those recommendations back. And this is basically our clinical and our wellness programs that we invest in for our members to aid them in getting the best healthcare possible. Next slide, please. All right, our history is we started CIAO 2008, well before I joined, and its goal was to access high quality healthcare, improving members' health status, and evaluate the performance of specific healthcare programs. 2022 is when we made a change, and we started bringing or inviting PEBB board members to join the CIAO and contribute to the conversation, contribute their points of view, their inputs on how they see things from the different their members are different between OEB and PEBB, so bringing in that extra perspective. As we all know, diversity of opinion and diversity of conversation is how we achieve our best outcomes. So bringing in PEBB's perspective into the CIAO work was very beneficial. We've had 2 members from your board participating in CIAO for two plus years now, and it's been very beneficial. And we want to make a proposed change to CIAO to actually bring this benefit of having both boards working together here into a permanent existence. Next slide, please. All right, so currently we have 4 OEB board members, 2 vacancies, and we have 2 PEBB board members. This is our current status. We are deeply embedded with staff at Mercer and doing the work and getting the data for us and taking on the questions that we get or that we deliver to the Mercer team, especially in how to achieve better metrics or improve metrics, or just getting deeper information on demographics. The members will elect a chair who will lead for that year, makes recommendations. We make recommendations to the OEB board for final decisions, and the PEBB board for specific projects that PEBB has participated in. We meet for 3 hours, 9 to noon, on the first Tuesday of each month. We do take the summer off as the staff and Mercer are both embedded in getting ready for open enrollment, and people are just away for the summer months. So we take those months off. Meetings occur the first Tuesday of the month, as I said, from 9 to noon. Next slide, please. Okay. Proposed changes that we would like to make. Want to change that membership balance from 4 OEB members to PEB members to make it official in our oversight, or in our charter, I guess is a better way of saying it, to doing 3 OEB members and 3 PEB members. Still 6 members on the participating in the conversation, but a balance of 3 OEB and 3 PEB members. We want to revise the charter to reflect that, and then everybody has a voting say in what CIAO is doing on an equal basis. However, I want to make a strong point here that we do honor the fact that the PEB membership and the OEB membership have distinct personality differences, distinct characteristics in what is best for each population. And so what we are saying is that the 3 members of each board will make independent recommendations back to their respective boards. Yeah, most of the time it's going to be common, because these are the kind of things, and this is why we want to work together, because most of the work we're getting and the data we need to make efficient recommendations are common, but there are times where the 2 different funding models for OEB and PEB, the 2 different characteristics, again, as I pointed out, for the memberships, could make a difference between the recommendations for specific healthcare options that are being evaluated. So we want to have that independent work. Although we're doing work together and we're doing that, it doesn't mean we'll come to the same conclusions. And so each of the boards will get an independent recommendation from their members of the CIAO work group. So the strong point to make there. Although we're working together, we are independent in what we do. Next slide, please. Oh, all right. First, I'll invite Glenn to make any comments that I failed to address, and then we'll open the floor.
No, I think you did a really good overview of why we want to do this. I mean, just if looking at our history, is that in 2022, we really just wanted to test whether, working in a more joint model, it was both efficient, effective. We also, we're also cognizant of Senate Bill 1067, which passed in 2018. I believe, and it really stressed that OEB and PEB should work together from an operational sense. And the response that PEB and OEB made was to have our work groups, try and work in a more kind of bicameral basis, so to speak, like our innovation work group. I would just say, looking at the medical PGs, doing these research groups has been extremely beneficial from the sense of it's much more efficient than doing parallel evaluations, both for Mercer as well as for staff. And we've had, as Bill pointed out, great benefit from really getting different perspectives and sharing information really kind of across the board. And we just right now just want to get your perspectives and your input on this, and we'll come back in December for an official vote with also a recommendation for a 3rd PEB member. And I would also
go ahead, Glenn.
No,
finish.
I'm sorry. I was just going to say, after Ali speaks, I would just also invite Greg and Andrea to kind of provide their input, as since they've sat on really CIAO and what they see as their experience.
Yeah, Glenn just said exactly what I wanted to say, so thanks, Glenn. And thank you to Greg and Andrea. I think that CIAO has been a huge benefit to OEB success, and I think with PEB getting in there and being part of that and working collaboratively. I think it's really shown, Greg and Andrea have really shown that this can really work and be a real boon to both boards. There's really no other comparator in the state than PEB has with OEB and OEB has with PEB. And I think there's so much that you can get out of that relationship. And so I just really thank Bill for offering that and Greg and Andrea for their participation.
Andrea and Greg, do you have something you want to add?
I do, yes. I was waiting. I found it very interesting how alike we are and how different we are. And it was interesting how some of the things that on the PEB board we had talked about, that of course OEB's talking and doing kind of the same thing. And it was nice to hear, as you were saying, it's nice to hear their views coming from, their side of the house and our views. And there were a few things, of course, this summer that we decided to do a little differently. But it was interesting because there were times when we gave some input that did not come up in their meetings that we had from our meetings, and vice versa. So it's just very nice to be able to have more information. I mean, the more information we have, the old thing, the more you know. It helps us, I think, make better decisions and will in the future. So it's been really nice. This is all, coming from my side of the house in corrections. I'm not a huge insurance person, but I have certainly learned a lot in the last year and a half, 2 years being on this board and then the board before. So definitely something I am happy to see happen.
Andrea?
I just want to exactly what Greg said. I think having that extra information and being able to see something that we didn't even think of that they're doing, and then being able to be like, oh, that's a great idea. I think that knowledge, and then also being able to really dig in deep into some of the issues, really gave us strength to have that bond when we are, talking to people. So I really appreciated it.
Anybody on the floor, on the board floor, do want to make a comment? All right.
Yeah, this is Sean. Thanks, Bill, for coming and presenting and being open for it. I think it's a great idea, and yeah, just appreciate OEB's openness to that. That's great. Thank you.
I'll turn it back over to Shobhan.
So,
you.
Dawn's
Go
here,
ahead,
so she's gonna take over chairing from me. So, go ahead, Dawn.
Thank you. Sorry about that. Appreciate it, Siobhan and Bill Graup. Thank you very much for the work, and thank you to CL for the work. It's a super important opportunity, and also for our volunteers who have invested a good deal of time. And I think that we all and public employees benefit from the time and the investment, the actual engagement with the work, not just going through the motions. So thank you for the work. And then I'll transition. I see that we are running a little bit behind, but let's go ahead and transition over to the PEB Member Advisory Council and Worksite Wellness Coordinating Council update. Brian and Teresa, the floor is yours.
Hello. So for those of you board members and our partners and folks in the audience who don't know me, I'm Brian Olson. I'm your OEB and PEB contracts team lead. I have facilitated our PMAC meetings for a number of years now. My colleague, Teresa Cross, who has a conflict and wasn't sure if she would be able to join, has done the same for the Worksite Wellness Coordinating Council since its inception, I believe, or sometime soon thereafter. Both committees are also supported by our colleague Rebecca Aparicio, as well as our colleagues over at Mercer. So both committees have been working together for a few years to help us better identify committee work, priorities, et cetera. And these joint efforts have resulted in what we're calling the PEB member wellbeing framework, which includes various strategies and tactics that the committees believe are important for best supporting our members' health and well-being. Since its creation, this framework has defined the committee work and priorities in addition to any other specific topics or assignments that the board assigns to those groups. And for today's annual committee updates, we're going to have Mercer present information related to this particular framework since it drives our committee work. So with that said, are there any questions before I turn it over to the Mercer team? Okay. So I believe we have either Dr. Stephen Nelner or Katie Scott that will be taking over.
Yes, I'll take over. Thanks, Brian. That was a great setup. And hello to the board members and guests. You can advance, if you will, to the next slide, please. So we're going to give you a quick view. We know we have limited time, so this will be a quick overview. And of course, you've got reference materials in the slide deck. We're going to give you a view of what we've accomplished in the last couple of years and what we're currently working on into the future within the context of what Brian just set up. We're going to share some information about a pilot project that we think is a very effective means of communicating benefits and opportunities for your membership. And then we'll talk about where we plan to go from here. So next slide, please. As Brian mentioned, we developed an overarching multi-year well-being strategy a couple of years ago and are now in the process of reviewing and updating the strategy, but also drilling down into the specific tactics that flow from those strategies. And we've got a few examples that we're going to look at briefly here today that show some of the things that we've been doing and some of the outcomes that we've already achieved. So one of the strategies was to collaborate with union leadership to learn more about the priorities in health and well-being programming to support their members. So we literally talked to members, union members in the PMAC and the council to test their interest in supporting communicating benefits and well-being initiatives to their membership. And I want to acknowledge that both Emily and Greg were early supporters of this from the union's perspective. Thank you, Greg and Emily. And that has trickled down into the members of the PMAC and the council who have picked up the mantle and are moving forward in communicating. And I'm going to tell you a little bit more about that pilot program that those union members are actually using to communicate. Next slide, please. And by the way, the three strategies and the tactics that follow are all somewhat related here. They're relating to understanding what programs are available. Are they inclusive of all the pillars of health and well-being that are in our well-being strategy? And then also it's important to note that we've been working closely with the Health Equity Work Group to review programs that they've already taken a look at, that they've teed up in terms of reviewing from the health equity lens. You can see, I'm going to spend a little bit more time giving the lay of the slide here, that we've shown the tactic to the left, then the priority level. We've narrowed the field just for the sake of prioritization to the higher priority activities, and the responsible parties being staff and PMAC and the council. And of course, in a few of these, you also see that the Health Equity Council is involved. And then a progress status. And for this review, both Health Equity Group and the Council and PMAC have looked at a few programs that are either in place now or intended to be implemented in January of next year. And in the second row, you can see we've retrospectively reviewed the PEBB program in the past. So a number of evidences of moving this forward and helping to really execute on the strategies and now the tactics that we've developed together. I'll move forward again for the sake of time to the next slide. Again, a related tactic and strategy. Now we're looking at specifically evaluating current programs, but this also applies to some new and potentially new programs that OMADA and Mighty Health weight management programs that we're referring to in the progress column are set to start on 1/1/25. So we're looking at some other programs alongside of those. Of course, WebMD was an example of that, and there's several others as well. And that'll lead us to the next slide, please. Another example of how we want to take a holistic view of providing health and well-being services and activities to the membership. We want to assure multi-modes of program communication and accessibility. Very much aligned with the discussion we've been having earlier today about the need to understand the various needs and the various challenges for the member population to access the various health and well-being services. All right, next slide, please. Again, showing another example of some other activities. We want to acknowledge that working with, we're trying to understand those social determinants of health and the other impediments and challenges that our population might have to access and participate in the services that are available. And you can see some acknowledgement to total worker health, community health worker, related to the earlier discussion. We're certainly reviewing those opportunities along with Christy and the Health Equity Work Group. Next slide, please. And please stop me. I'm going quickly for the sake of time. This slide just shows the various programs and services that the Health Equity Work Group has taken a look at already this year. And we, the PMAC and the Council, are anticipating looking at more of these as we go forward into the future. So the next slide will give you an example of that. Before I get to that next slide, we'll talk about the Train the Trainer. This is, I alluded to this pilot project a moment ago. This was an opportunity to, we thought, to find a way to use peer-to-peer communication to help promote the programs and services of the PEB for its membership. So we tried to identify a service or program that really was accessible to the majority of the population. So we settled upon Canopy, the EAP service, because truly everyone does have access to that in the PEB population. And also because we know that they have some very crucial needs for the population around mental and behavioral health. But in addition to that, we recognize that there are many other services that Canopy and the EAP provide that are not well known and not well utilized by the membership. Well beyond the mental health services that often people default to thinking about the EAP for. So in May, we started to work with Canopy to see if we could narrow down a slide deck, if you will, a presentation deck that could be used by the PMAC or council representatives to take to their union group or to other peers, to other groups without in their workplace. We took that first draft to the PMAC and the council in June, got some feedback, did some fine tuning, and brought it back to the July meeting. And at that meeting, we asked if there were any other fine tuning opportunities, and they said, I think we had 3 members raise their hand and say, no, let's start with this. I'm willing to take this to my group and see how it goes. So indeed, we had at least 3 members of the PMAC or the council who took this to their various constituencies. And at the September PMAC and council meeting, we heard feedback and that were very positive. In fact, I think we can move to the next slide to give you some of that feedback. We're going to continue this effort going into the future, but some of the early feedback we've received was presenters got really strong and positive feedback from sharing with their peers and their groups. Groups varied in size, and one presenter was asked to presented to a relatively smaller group of 8 people, but was then asked to lead this training for a much larger group at another time. So that was a good sign that it was effective. Smaller groups are not aware of the Canopy EP program and have registered and actually started to use the program. And I think the overall feedback was the presenters found that the deck that was provided to them was flexible. They could tailor to the needs of the population or the audience that they were working with. So we're very excited about this. The early feedback, as you can see, is very good. We think this similar model can be replicated for other services and programs that PEB offers. And I think you all know the challenge of communicating to our membership, right? Very diverse, very dispersed. Work sites vary greatly. So we really think that peer-to-peer communication, when available and when appropriate, is another great way in our multi-source effort to try to communicate to our membership about what's available to them. We're going to move to the next slide, please. And move into the last area here. So as I alluded to earlier, this tactical work around identifying programs, reviewing programs that are appropriate for the membership is an ongoing effort by the Council and PMAC. And we've created a matrix of filters that we think could help us identify which programs to evaluate. So you can see here some of the filters that we've postulated: board interest, current member experience and feedback. Does it address a top chronic condition or a top area of spend or both? What's the potential impact on the population? Does it serve a large segment of the population or a smaller slice? Do we have evidence that there are good outcomes from those types of programs? Is it an existing program or a new program? Timing. How long does it take to review the program? How might it align with the renewal process to provide a recommendation to the board about renewing or not? And then, of course, always keeping tied into the work of the Health Equity Work Group and the Innovation Work Group, and perhaps CIO as well, or any other work groups or other collaborators that might be appropriate. And then finally, and not unimportantly, what is the impact on administrative resources to be able to facilitate any follow-up action? So again, a whirlwind tour there of what we are doing. Next slide is just a quick example of putting this filtering process into action. We've selected 3 programs that are one that's already in place. OMADA Diabetes Prevention Program is in place. And as I mentioned earlier, the OMADA Weight Management and Mighty Health are weight management programs that are scheduled to launch on 1/1/25. And you've seen this is just an example of how we use those different filters to help identify whether or not these were appropriate programs for us to look at. You can see the board interest evaluation is blank. So if you have ideas and recommendations, we're open to them. And we certainly will be guided by your interests in areas that are important to the board. Last slide, I think I might have another slide as an example, but we can go to next steps. So ongoing work just to show that this is a continuous process. And as Brian said earlier, the overall well-being strategy framework and now the tactical roadmap is what is guiding the work of the PMAC and the council for the rest of this year and into next year. And we welcome your input and guidance, of course, and are happy to support you in any way that we can. Thanks very much for that speed event.
Thank you for that very speedy presentation. Any questions or comments about this before we move on? Emily.
Sorry, I don't want to take up too much time, but that was a really exciting presentation for me. And as I offboard as OHA's first vice president for SCIU, and our emphasis on mental health and psychological safety for our members at OHA, I would love to connect later, maybe offline, and share. I just finished a Total Worker Health Train the Trainer training, and centered on equity, worker voice, mental health, psychological safety, and we're potentially going to pilot something at OHA that could actually help inform the other state agencies in that context. So I don't know if that is okay to do, but I was very excited to hear about the pilot. So congratulations.
Yeah, let's connect. And Ryan, I'm sure we can connect as well. The learning from each other, what's worked, what we can improve upon together. I think we can fine tune this and make this, as you're suggesting, a very effective tool for communication. Thanks, Emily.
Great. Thanks. Thank you. Greg Clauser, last comment, please.
Yeah, just one last thing is we have, as many of you know, with this coming on, I think it would be something good. We have the Uplift which a lot of our people take and go through. So it's kind of the same thing. We give them an idea of what's there. It's more of an in-depth idea of what the insurance is and how it is. And I know the unions helped pilot that up with Oregon as well, which a lot of our people now take their first week, so they know exactly what they're getting, a lot of their benefits. And I think canopy is another thing we need to throw in there. So thank you very much.
Thank you, Craig. And with that, I'll go ahead and ask Rose, has anyone registered to provide public comment on the meeting?
No, you don't have any oral public comment, just what I sent you.
Thank you, board members. I'd like to remind you that there was one written public comment about GLP-1s submitted anonymously, which we will no doubt be discussing at future meetings and in our retreat. And before closing, I'd just like to encourage board members to consider participating in the work groups if you are able and interested. I think an enormous amount of perspective derives from that work, and it makes the work that we are able to do here on the board better when members like Greg and Andy are able to come back with that under their belt and bring those conversations into our meetings. Thank you to all of you for joining us this morning and in fact this afternoon, and I wish you a beautiful month. We'll see you next month.
Thank you.
Thank you. Thanks, everybody.
Bye-bye.